The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Participant, glad to join you. We will soon commence the webinar. We have a good number already joining us, but just to emphasize that since it's advertised to start by 3 o'clock, in the next few minutes we'll soon start. We're happy you are here with us, and we hope it will be an interactive session. Thank you. Okay, thank you there, listeners. It's time for us to kickstart. It's 3 o'clock already on today, 15th of March, broadcasting from Limi Children's Hospital. You're all welcome. So we'll start the presentation today. We are Limi Children's Hospital.
We are a designated specialty hospital for neonatology, child health, as well as adolescent medicine.
Yeah, Thank you. Okay.
And we are driven, and what drives us? We're driven by our vision, which is to become and remain the leading regional, world-class, patient-centered children's hospital. And we do this by working on appropriate, innovative technology based on godly principles.
Yeah, so we know that for a family to be happy, the child has to be happy. So a healthy child is a happy child, and a happy child makes for a happy home. So we are driven by that to make sure we consistently give good results. But please, we want to be very sure that participants can hear us. So if you can you just put yes into the chat box or question and answer, so we are very sure that we are together. Thank you. Right. So today's presentation is set. So what are we presenting to him?
So now we want to demystify pediatric electrocardiography. So we want to remove the mystery, the enigma around what is pediatric ECG.
Yeah, thanks. So we want to make the presentation as simple enough for this brown-skinned African girl to understand. So we are very sure, since we have doctors among us, we are so proud to have respected colleagues and very senior colleagues, those that taught our teachers, being present as participants. We feel very honored, but we'll go right to the point. I am Dr. Igoche Peter.
I am Dr. Ejemeireile Omokhuale.
All right, thanks. So, yeah, so we'll start with the indications first of all. Now, today's presentation is going to be very practical, so we wouldn't go in. We just want to make sure that participants are able to know why an ECG has to be done and what it represents.
Exactly. Also, we need to have our writing materials, your pen, your paper, and you have to also pay rapt attention so as not to miss anything important during the lecture.
Okay. So someone is saying, I also cannot hear the speakers, even though it seems they are unmuted. So let me be sure. Please, can anybody hear us? Someone say, I am not hearing anything. Please help. So, can anybody please hear us? Let's be very sure. Yeah, so, okay, thanks.
Okay, thank you.
Yeah, okay, thank you.
Thank you very much.
Yeah, so thanks. So we can move on. So syncope is an indication. So a child that faints. So syncope can be of cardiac or non-cardiac origin.
Exactly.
So when we find children, okay, you have during a long assembly line in school and a child suddenly collapses. It could be of cardiac origin, it could be non-cardiac. So we like to know if it's cardiac, because the syncope of cardiac origin could either be because of tachyarrhythmias or bradyarrhythmias, whether it's from a ventricular tachycardia, whether it's from an SVT, whether it's from atrial fibrillation, or a bradyarrhythmia, such as complete heart block, even sinus bradycardia. So these are known indications for ECG. Yeah.
And even also something like acute traumatic fever. Now, you remember the Jones criteria, we have a prolonged PR interval. So now doing ECG will help us to know how the heart rhythms are. Also, something like Kawasaki disease, which is a very common disease that affects children, especially abroad, like US and Japan. Yeah. Now you may see some non-specific ST changes in someone who has Kawasaki disease. So it's good to know an ECG. Also, let me say an effusion now, which you could see sometimes low QRS complexes, especially in pericardial effusion. So this is helpful to have an ECG as well with this kind of condition seen.
Yeah, it's important. Also, even in routine emergency room, if we want to get electrolytes, so we could tell electrolyte changes from the ECG, potassium, and that's part of one of this. That's one of the slides we shall be discussing today. Potassium, even calcium disturbances can be found. Children who have undergone cardiac surgery, or children preparing for cardiac surgery, for who we diagnose any heart condition, either it's acquired or even if it's congenital. Yeah, it's really, really important that we know this, we get ECG done. Yeah, so before we get into the meat of the issue, we just want everybody to relax.
Taking a deep breath.
Take a deep breath
and breathing and
breathing. So our duty today is to make pediatric ECG easy peasy
Lemon
squeezy. So that makes it really, really easy, right?
Yes.
So there's good news for the presentation today, and that's that we have a lot of similarities
Yes,
to
with
the
the adult
adult
ECG, exactly.
ECGs. Yeah. However, there are some peculiarities.
So
Right?
now, children they're more of right heart dominant, so they have a thicker right ventricle. So you're going to see more of right-sided chest leads.
Yeah.
Also, every child, you have to take the age very seriously because we have age-dependent and age-specific normal values.
Yeah.
So the child's age is very important to have a correct ECG tracing.
Yeah.
Also, we have specific T-wave age-related changes for children in particular age group, especially from infants to even the older pediatric age groups.
Yeah. So just like we have all our values, even food local results, age dependent. So our values, but we'll try to make it very easy so that we don't end up cramming figures, but we'll just cram the number of small boxes, number of big boxes, and then we make progress. Okay, so the next slide, we'll move. Sorry.
Okay, so please let's get our writing materials ready. We're about to start.
Yeah.
In earnest.
So this is just the preliminary slide to draw our attention to the right-sided chest leads.
For example, you can see the V4R and V3R placements.
Yeah.
And you can see that they correspond to the V3 and V4 chest leads on the left.
Yeah.
Just the same thing, just on the right side. So this is more because remember, like I said, children have more of right side dominance. Yes.
Yeah.
Just remember.
So every other lead placement is just like that of adults.
The adults.
Yeah. So first things first, the basics. So we will be talking a lot about small squares, two small squares. Yeah. So that's it. So this is a typical tracing of the ECG waves, similar to that of adult ECG. So we look at deflections above the baseline. The baseline is actually the isoelectric line. So the first positive deflection above the baseline is the P wave. So the first negative deflection is Q wave. Now, the Q wave, R wave, and S waves form a complex, the QRS complex. Yeah. Then the other positive deflection is T wave. So whereas we have 3 positive deflections, we have 2 negative deflections. So if we take the distance between the entire length of a small box horizontally, it tells us time is a duration. So we prefer to use seconds, so 0.4 seconds. It therefore means if we have 2 small boxes, 0.08 seconds and 0.12 and all like that based on the number. So 1 small box horizontally is 0.04 seconds. Now, 1 small box vertically is 1 millimeter. With this said, I think we'll stop about this slide and just make progress.
Okay, so now this just shows us basic steps. Now there are different steps for ECG. We have some 10 steps, some 5 steps, but it just shows like a quick 6-step way to try and read an ECG. So we'll start with these 6 steps as we have seen now.
Yeah. So a disclaimer quickly. Pediatric ECG very, very broad, and I'm sure everybody what there's to do to make it that every participant can make very good interpretation from the ECG.
Exactly.
So we may miss out on some theoretical details and focus on very practical ones that we'll get. Other details can be handled subsequently. So we start with identification and lead placement. Yeah, so you had said earlier that it's important we know the age of the patient. So just like we have biodata, it's very, very important. So we have that, but very important, we want to know about lead
placement.
Yeah.
Now, let's look at this ECG strip now. So now we can identify our P wave.
Yeah, so P wave, the first positive deflection above the baseline. Yeah.
And so normally P wave should be upright in lead 2. Now you can see our lead 2 on the second line. So now the P wave should be upright in lead 2 and inverted in the AVR.
Yeah.
And also, so if you see an ECG strip and the AVR is upright, that means there's an issue with that ECG.
Yeah.
Probably an incorrect lead placement when the child was being taken for the ECG.
Yeah. So because you see, many times in many hospitals, it's actually not the doctors that do the ECG placement, so the ECG technicians. So we are supposed to be able to identify that, oh, this lead placement was not right, and so we will not be able to make the correct conclusion. It's important we know that. All right. So now it's time to get ready to participate.
So our pencils and our papers
Yes.
ready.
So we ask questions. We want to be sure that we are learning together. So for some things, instead of teaching, we ask questions, and then we will like to look at the chat box to the question and answer to get your responses. So fine. So want to calculate heart rate.
Yes.
Now we have two ECG tracing. So there's one that is black and white. Some people don't have black and white pictures. So black and white. Report A is black and white, and B is colored. We want to calculate the heart rate for these two ECG tracings, and it's important we identify one fact that at the rhythm strip lead 2 have equal RR intervals in tracing A, while the RR intervals are unequal
in the B.
Yeah, so it's an irregular rhythm in B. So calculating heart rate is not a flat formula. It depends on, so what's the heart rate you quickly want to check? Is it sinus? Is it not non-sinus? We shall look at the rhythm because that's the next concept. So it's quite straightforward to calculate if we have equal interval RR waves. And we say for that, just randomly look at the tracing and get the R wave that aligns with a thick line, then count the number of big boxes in between the RR waves. Simple. So if we, in this case, so let's just see. So we ask. So the number of big boxes in between the RR interval, so 300 divided by that. So going by this, can we look at the chat box, the Q&A, your answer? Let's know what is the heart rate for ECG tracing A.
For the A tracing.
For the child in A. So we'll wait to get response, please. Let's be sure that we are together. No answer yet. So you can type your answer. We've said, okay, so so please type answer into the Q&A. Let's be sure we are
They're
together.
all following.
Yes. So we said the number of
that's the RR interval. Now the big boxes in between two R waves.
Yeah. So if we have just one big box, it will be 300 which is 300. If we have two, then it will be 300 divided by 2, which is 150. If 300 divided by 3, which is 100. And if it's 4, that will be 75. So it's so I think we have some answers already. Let's see.
Yes, we see.
Okay.
Lawal
Abdul Salam
104.
104. And this person is accurate to
Very
the nearest
accurate, exactly. And we are seeing 100 with Rafiat Abdul Ghaffar.
Yeah, and we are seeing 75. So fine, let's see. Let's calculate together. It's actually for tracing A.
Exactly.
So if you look at the cursor, the cursor moving on the screen, I take this as where the first R wave is. So we count big box 1, big box 2, 3, and 4. Yeah. So we have a little just above it. So approximately 300 divided by 4 will give
around 75 beats per minute.
Yeah. So 75. So look at the S, and I think those who got it is our virtual. Yeah. Femi.
I think 79 too is close.
Yes, 75 too. All right, fine. So we are very happy we are together. So let's go to
tracing B now.
Tracing B, which is slightly technical. And let's see. When the RR intervals are not equal, we want to count there are various methods.
Yeah, there are various.
So you could actually count in between each of them like we did for A and take the average, but that's going to take a lot of time. So for a 6-second strip, so you count 30 big boxes. Within 30 big boxes, you just want to know the number of R
as they
being multiplied by 10. That gives you the
that's your
approximate
heart rate.
So if we count from the beginning, our 30 will be somewhere here. And so if we count the number of R waves in between there, about 9 of them.
That's
One,
9
two,
R waves.
so 9 times 10 is 90.
90 beats per minute.
90 beats per minute. So it's important we know that for irregular rhythms. Yeah. So let's make progress. So we've talked about heart rate. So let's go to rhythms.
The rhythms. Okay. And so now we want to know what is a normal sinus rhythm.
Yeah.
So I think first of all, sinus rhythm means that it originates from the SC node.
Yeah.
First of all, so now there are 3 things we have to look at. We want to look at our P wave, our QRS complex, and our R waves. Now, first thing, P waves, are they all similar? Do they all look the same?
Yeah.
P wave, remember, it has to be upright. All P waves must be succeeded by a QRS complex.
Yes.
And for the QRS complex, all of them should be preceded by a P wave. These two look the same, but they are actually very They are very dissimilar.
Yeah. So it's important that we understand that for every P wave, there is a QRS complex that comes after it. And for every QRS complex, there's a P wave that comes before it. Yeah.
And last thing, you want to also have equal RR intervals to make it a normal sinus rhythm.
Yes. Okay. Having said that, we could have an ECG tracing that meets all these criteria for P wave, QRS complex, but default in the RR interval. In the RR interval.
It can have irregular RR interval.
Yeah, so that becomes sinus arrhythmia. So it's important we note that. So if we have normal P waves, they're all looking like twin brothers.
And sisters.
And then lead placement is okay. And then QRS complex and P waves, they are present where they should be. Even if RR intervals are not normal, it could be due to respiratory changes in these children, and it could be sinus arrhythmia. Now, look that the abnormal rhythms, which we will not talk about now, want to see tracings of normal sinus rhythms, but know that it still follows the P wave and QRS complex relationships. Yes, so fine. All right. So having said this, please let's get ready to answer again. Let's be sure. So please look at the normal rhythms very well again, and let's see. We go to the next slide. Which is which? Which one is sinus rhythm? Which one is sinus arrhythmia?
Is it A or is it B?
Is it A or B? So we'll be happy to get answers. So we are in the chat box. We are watching again to see if our explanation
was clear enough for them, for everyone to follow. So I hope we had the answers right.
So whether we spoke English or Greek. See which is which. Is A sinus? Is B sinus rhythm? Is A sinus arrhythmia? Is B sinus arrhythmia?
Okay. So we have some answers
already.
Have
some answers already. Wow. Okay. So Rafia said A is sinus rhythm,
B sinus arrhythmia.
Okay, fine. At this point, I think Rafiat can join the presenters. Yes, we are so impressed. We are so impressed. Okay, fine. So look at the let's look at it closely. If we take the rhythm strip lead 2, we have P waves, and all the P waves
all look similar, exactly, and they are all upright.
Yeah. So normal direction, normal amplitude, normal morphology, normal duration. They all come after every P wave. There's a QRS complex, and before every QRS complex there is a P wave. Yeah, and then the RR intervals look they look equal. So actually, A is sinus rhythm. Now, if we look at B meets up all the every other criteria for sinus rhythm, except that the RR intervals are not similar. So if we look at this tracing here, this RR interval is much longer than the preceding RR interval. So we can say confidently that both tracings are normal. It's just that B is sinus arrhythmia. Now, so we do not misinterpret and give. Someone said both at the beginning are sinus, but later became abnormal. Wow. Okay, fine. So from gross morphology, we say A is sinus rhythm and B is sinus arrhythmia. Okay, fine. Let's make progress. Our mouse. Okay, no. Can it be controlled? Okay. Next. All right. Fine. So having discussed rhythm and rate, we want to see tachycardia. So we've discussed rhythm, we've discussed rate. So let's look at fast rate, which is tachycardia. So on this slide, we have basically two types.
Yeah. Okay, so we have the sinus and we have the supraventricular.
Yeah.
Now just to actually point out, for the sinus rhythm, the rate is usually not as fast as the SVT.
Yeah.
Now, we know in kids that we don't have up to 220, but if it's going to have even more than 220 beats per minute for the SVT.
Yeah.
Also, for the sinus they have visible P waves. You actually see visible P waves on the tracing.
Yeah.
However, for the SVT, you can't really see any P wave at all. So that's one way to know.
Yeah.
For sinus we want to have a fast rate, but not as fast as an SVT.
Yeah.
And you also have visible P waves.
Yes. So it's important we look at the rate and presence of P waves. So we have other parameters listed on the screen. However, we are talking, there is an ECG tracing in front of us. So I'm going to be interested in just the rates dependent on the age of the child. Please note, because the next exercise will test whether we understand this screen. So the presence or absence of a P wave will tell us, looking at the rate, for an infant, babies less than 1 year, if the rate is more than 220, very likely sinus tachycardia, where P wave is absent. Okay, fine, let's see.
This is the next slide.
The next slide. So this slide now, please. Which is which? Is this sinus tachycardia
or SVT
or supraventricular tachycardia?
This is a 3-year-old tracing.
Yeah, fine. So this is the tracing for a 3-year-old. So please, at this point, age becomes important. That's why we said when we have an ECG tracing in front of us, it's important to have the biodata and some bits of the clinical information. So the question is clearly in front of us now. Can we find attempts just to be sure that our previous slide made sense? So is this tracing in front of us sinus tachycardia,
or is it an SVT?
Or it's an SVT for this 3-year-old? So we wait.
Okay, Rafiat again.
Okay, fine. Wow.
Yes.
Okay, yeah. Fine. So okay, fine. So it's getting more interesting. So we have a sinus tachycardia answer. We have a supraventricular tachycardia answer in front of us. Yeah. So more answers. Let's get a tiebreaker.
Let's see.
So there's a tiebreaker.
Yes.
Sinus tachycardia, P wave present. Chukudi. Yeah. And then
okay, sinus tachycardia. Yes, sinus tachycardia.
So we are in the red chamber. Exactly. We are in the red carpet chamber right now. And so we want to say the sinus tachycardia have it.
They have it.
So, all right, fine. So let's look at the tracing.
Why do we really have it?
So this child is 3 years old. Let's count the heart rate. So between this R wave and this R wave, we have two big boxes. So
that's about 50 beats per minute.
So 300 divided by 2, which is the heart rate is 150. This child is 3 years old, so it's more than an infant, and is 150. And then we have P wave before every QRS complex. So let's go back to our table. So this child is 3 years old and has heart rate of 150. So it's less than 180. One feature of sinus tachycardia. The child also has visible P waves on the tracing. Yeah, so we say that those who pick sinus tachycardia have it. But we have more answers coming in. Yeah. Okay. So please, if chat disabled, please just put answers in the Q&A
section.
Yeah. Okay. Yes, fine. So fine. So I think we are making good progress. Fine. So this is sinus tachycardia.
Now the next slide.
The next slide. Let's look at it carefully. And let's try to give an answer. We say this is a 3 months old. This is a 3 months old child. Yeah, an infant with this tracing. Now, is this sinus tachycardia or is this supraventricular tachycardia? So again, we wait for answers quickly. Let's be very, very sure that We are making progress. Wow. Okay, fine. So we have an
Yes,
answer
we have an
already.
SVT
SVT.
already.
Fine.
SVT,
Wow. So
yes.
someone gave another P. Okay.
No, that was the
Okay, fine.
previous.
So SVT rate
Rate is 300. Yes, that's very good.
SVT. Fine. So I think we can take it at this point.
Mhm.
So the SVTs have it.
The
In the
SVT.
red carpet chamber today, the SVTs have
We
it.
have it.
Good. So let's look at it closely again. So between two consecutive, that's the word, two consecutive R waves, we just have one big box.
One big.
So we say 300 divided by 1,
Which is 300.
which is 300. And this child is 3 months old, is an infant. And it's more, this means it's more than 220 beats per minute, tilting towards supraventricular tachycardia.
Yeah.
Now, if we look at the tracings very well, we know really discernible P waves in between. So absent P waves and a heart rate of 300 in an infant of 3 months old, this is supraventricular tachycardia.
And also remember, we also have narrow QRS complex here. Just to note.
Yeah, fine. So so some other slides in front will tell us more about supraventricular tachycardia. But for us to know, the QRS complexes are narrow. And when we say narrow, less than 0.09 seconds. And we say one small box is 0.04 seconds. So if it's 0.09 seconds, so about less than
3 small boxes.
Yeah, less than
3 small boxes.
Fine. So now again, assuming we don't have the time to, let's say it's so bad, we don't have the time to calculate the the heart rate, and we are not looking for the P wave. SVT has this unique morphology. So just look at this and identify from pattern. This is how SVT looks. Yeah, it's crowded in terms of the QRS complex. It's crowded in terms of the RR waves. And there are some positive deflections between the R wave, but which is not P wave. Yeah, so it's important to know this. Yeah, fine. Okay, so we've talked about the normal rhythm. So let's go to abnormal rhythms now. So please, let's pay attention again because we want to make it as interactive as possible. Yeah, as interactive as possible. While presentation is going on, please, you are at liberty to ask questions. I will answer them. But let's look at abnormal rhythms. Please remember, sinus arrhythmia is not considered an abnormal rhythm. Yeah, so it's a variant of normal.
Abnormal rhythms.
Yeah, so abnormal rhythms.
Okay, so now, as I said previously, we're going to have the P wave related or QRS complex related.
Yeah.
Now, for P wave related, we look at more of if the P waves are they present or absent. Now, if you have absent P waves, and remember, if the QRS complexes are narrow and they are irregular, narrow meaning that is less than 3 small boxes now. We think of an atrial fibrillation.
Yeah.
Now, if we have narrow QRS complexes, but they are regular, they occur at regular intervals, think of a junctional tachycardia.
Yeah.
Now, if QRS complexes are wider, that means it's more than 3 small boxes. A man should go towards a ventricular tachycardia.
Yeah, yeah.
Now, if you have
no, fine. So let's not go too fast,
let's take it
because we have a lot of questions following just this slide we are discussing. So there is no P wave. So P wave is absent, the first one we are talking about. And P wave being absent, we're now looking at the QRS complexes. So are they narrow or wide? If P wave is absent and the QRS complex is wide, think of ventricular tachycardia. So P wave, you cannot identify a P wave, but the QRS complex is just unusually wide. Think of a ventricular tachycardia. Now, in the event P wave is absent, but QRS complex is narrow, you now start looking at the intervals between the RR intervals, interval between 2 consecutive R intervals. Are they regular consistently, or are they irregular? Good. So if it is irregular, you are thinking of atrial fibrillation. Now, I don't know, I wish to ask a question, but the chat box will just be, the Q&A would have just been, it will take some time for people to answer. So how then do you differentiate between sinus arrhythmia and atrial fibrillation? That's the question. So how do you differentiate? Because sinus arrhythmia is normal, atrial fibrillation is abnormal.
It's abnormal.
So just to get the answer, the difference is the presence or absence of a P wave. So because the RR intervals will not be
They won't be
equal
in sense
in
arrhythmia
both
or
atrial fibrillation. However, the QRS complex in atrial fibrillation is really narrow, and then you can't find a P wave.
You can't find a P wave.
Yeah. So for junctional tachycardia, you have it regular. Fine. We'll look at the slides and see. I hope we are following, because the questions will tell. Now, if we have multiple irregular P waves, remember we said for the rate to be called sinus, the P waves should look identical. So they should look like twin brothers.
Like twin brothers. But now they're going to be looking irregular.
Yes.
Very irregular.
But they're going to look irregular, right? So if the P waves are multiple irregular P waves, usually with a sawtooth baseline, it's an atrial flutter. Good. So these are P wave related abnormal rhythms. Now, QRS complex abnormal rhythms will be treated as a slide on its own, because that will be AV blocks. Now, let's see if we have, okay, now there's a question. How do you differentiate between SVT and junctional tachycardia? Fine, we'll look at them first, so that it will be very clear.
So we'll see
the age of the child, so that to determine the rate. The rate is super fast. More than 220 if it's an infant, more than 180 if it's a child. Good. And then the QRS complexes are very narrow.
They're very narrow.
And then you don't have a P wave. Now, for junctional tachycardia, good. So for junctional tachycardia, they are narrow, but regular.
They also don't have a P wave.
They don't have a P wave. Yes, okay. So good. We'll look at it. Good. That question is very good. And that was why, let's go back to SVT. I said in SVT, pattern recognition. Remember when we're on this slide, I said even after you've accounted for P wave absence, QRS complex being very narrow, and heart rate being very fast, there is pattern recognition for ECG reports, and SVT has this unique pattern. We will look at the report of the junctional tachycardia, and then we should be able to differentiate between the two. Just a little more on our pediatric tachyarrhythmias. When we say narrow QRS complex, we actually mean when the QRS complex is less than 0.09 seconds.
Or less than 3 small squares.
That less than 2.5. Because two small squares equal to 0.08 seconds. Yeah. So if we have a narrow QRS complex, we're talking about atrial fibrillation, atrial flutter, sinus tachycardia, and SVT. But if it's wide, you're thinking of a ventricular tachycardia. There is an unusual supraventricular tachycardia, in which case the QRS complexes are wide due to aberrant conduction. Maybe at conduction abnormalities, it will be clearer. Fine. So we have this tracing now. So let's get ready to answer. Let's be sure we are together. It's getting more interactive. Probably more tasking. So because we've discussed quite a lot of abnormal rhythms. So remember we said P wave related is P wave absent. If P wave is absent, what about the QRS complex? If QRS complex has been accounted for, what about the RR interval? Yeah. So I do not know. Can somebody hazard a guess what this? Yeah, under Q&A. Can you tell us what this tracing is? No discernible P wave, narrow and irregular. Which type of abnormal rhythm could this possibly have?
Okay, we have AF.
Okay, when we say AF, we are confused whether it's atrial fibrillation or atrial flutter. We want to count as much as possible. Whether it's an atrial flutter or
we have other answers as well.
Okay, so another.
So the AF, we have atrial fibrillation. Yes, atrial fibrillation. I think the atrial fibrillation.
So everybody, so this is atrial fibrillation. So let's look at it closely. The QRS complex are really narrow. really narrow, just maximum too small. And look at this. Look at this. Between this R wave and this R wave is so long. The one following it is so small, just so narrow. Yeah, that's how it is. Very wide RR interval here, whereas this is narrow. Let's see if we have some. Yeah, so atrial fibrillation,
So I think most people actually got it as atrial fibrillation.
Yeah, so it's important.
So I think we're really following.
So atrial fibrillation is really a challenge, and when you make this kind of diagnosis, what do? You want to control the rate, right? And you want to make sure that, so there's fibrillation. It's not the atrial, it's just there's quivering, just like
of the atrium.
just like somebody say in English, somebody is shivering like a soak and caged rat that is not contracting very well. So the contraction is a problem. So we want to control the rate and want to prevent thrombus formation. Want to prevent intracardiac thrombus. Want to correct for the rate. So to prevent that thrombus formation, you want to anticoagulate with warfarin. And then
use amiodarone to help the rate.
Yeah, calcium channel. So when this is identified, we do not pass it on. Fine. Next, tracing. What could this be?
We have some answers.
Can we have some answers? We are very happy to have people identify the previous one. I don't want to mention the previous one. So what could this one be? We have narrow irregular P waves. So P waves are present in lead 2, but they are actually multiple and irregular. What could this be? Can we get your answers, please? Yeah, so
we have atrial flutter.
Good. Someone has even said sawtooth appearance. Very good. So this is atrial flutter. Good. So this is atrial flutter. Please, atrial AF. Atrial fibrillation, atrial flutter. Although commonly say AFib for atrial fibrillation and atrial flutter commonly. So let's go backwards. This is atrial fibrillation. There is no sawtooth appearance of the baseline.
Yeah, no discernible P waves in the previous.
Yeah. So, but there are multiple P waves here, and the problem is that the P waves are, so it gives this irregular baseline. Sorry, it gives this regular, unusual baseline. Yeah, use regular, unusual baseline. So what do we do? Where do we find this? If you find this, we know that the sinoatrial node that generates the rhythm of the heart is in the right atrium. So any scar that affects the SA node can cause atrial fibrillation. So if a child has an atrial septal defect that was surgically corrected and there was healing with scar formation, the child can have atrial fibrillation. It's very, very important, we know. So any other surgery that occurs in the right, that there was incision, there was scar formation in the right atrium, we think of, and we have this appearance.
Points was an atrial
yeah. So want to, for this kind of patients, you do acute rate regulation. You could use digoxin, rate control. There could be need for acute cardioversion, and then that the chronic suppression because the scar remains there. Yeah, so it can actually get fatal. So we do not want to. So for this presentation, we want to be able to identify. Want to know which patients possibly could have it. We want to know what to do. So digoxin will do rate control in this kind of patients. Now the next slide is in front of us. What could this be? So our abnormal readings we've discussed so far today. We've talked about atrial fibrillation, atrial flutter. Now we have this ECG tracing in front of us, which the QRS complex is still really narrow. And then we have absent P waves. Good. What could this be? What could this be?
Can we have some answers?
Can we have some answers? Yeah.
Let's try and move our minds a little.
Yeah.
So.
Why? So no, we'll be careful. Let's be quiet. Let's be quiet. So the first person has gotten it already, but let's be quiet. Wow. Okay, fine. Okay, fine. So maybe in mathematics, if you have 3 points on the graph and you connect the line, you can get your slope. Okay, so let's wait for.
Last
Oh,
question.
perfect. So now this is junctional tachycardia. So there was a question in the chat box. How do you differentiate between junctional tachycardia and supraventricular tachycardia? Yeah. So even if we do pattern recognition, we know the pattern of an SVT. We know the pattern of SVT. Good. So remember when we differentiated between SVT and ventricular tachycardia, and sinus tachycardia, we had rate corrections, rate considerations. So in this case, the RR intervals are equal. We do not have P waves. And the QRS
have narrow QRS complexes as well.
So if I would say the difference between supraventricular tachycardia and junctional tachycardia is in the rate. Is in the rate. So it's in the rate. Fine. So in these patients with junctional tachycardia, so fine. The next question from this: what then is between between junctional tachycardia and sinus tachycardia? So because we've said the difference between a junctional tachycardia and supraventricular tachycardia. Yeah. So what of sinus tachycardia and junctional tachycardia?
So I think we can have some answers to the chat box.
Yes. So that may be.
You could have some answers.
Okay.
Not following.
Okay, fine. Someone said, please, I'm not following. Which of the leads do you start your assessment from? I equal RR. Okay, fine. Okay, fine. So no problem. We can answer that. We said to read an ECG. You get the biodata and you want to know some specific things like age to identify the patient, which we call guess in our hospital. You want to be sure that the P wave is upright, and the AVR, you want to be sure inverted. So that is okay with identification. Then we went to rate and rhythm. So to answer the question, where are we looking at in particular? So to answer your question, we are looking at the rhythm strip. There's what we call rhythm strip, which is lead 2. Now, if we look at this ECG tracing for junctional tachycardia, we have lead 2 here. If you're looking at my pointer, but lead 2 is expanded downwards to give us the entire length, so we can tell what is happening across several pattern as well, so that we can identify pattern. So when we are talking about this absent P wave present, we are considering the rhythm strip, which is lead 2. For this presentation, we are strictly looking at lead 2. We don't know if we have other questions.
I think we have some answers. Maybe
so can we get a recording of this after this for those
yes,
so how is the presentation? One of our presenters will give a detailed answer to this at the end of the presentation. So the answer is yes. For how to get it, we'll give the answer. So QRS complex will be absent.
No, will be at least 0.09 seconds.
Okay, at least. Okay, someone is giving us an answer.
Yes, the answers.
Okay, fine. Yeah. Okay. It's okay, fine. So this is like to differentiate between sinus tachycardia and junctional tachycardia. P wave, presence and absence of P wave.
Yes, that's the P wave.
Presence and absence of P wave. So for sinus tachycardia, it is sinus rhythm. So there would be P wave. But for junctional tachycardia, it's an abnormal rhythm. There will be no P wave. Yeah. So please, my chat box has been disabled. I'm not able to write, see or read. So please just so chat box, please, for today's presentation, please kindly make your comments into the Q&A section. We will read out other people's comments for you. Thank you. Yeah. So difference between between sinus and junctional tachycardia. P wave.
The P wave. Is it there or is it not there? That's how you differentiate it.
So please, can we get recording? Yeah,
yes, we can do that afterwards.
Okay, fine.
Also, how do we treat this when you see this?
Yeah.
That's another important.
So we've said that it can occur in patients post-surgery.
Post-surgery as well.
Yeah, as well. So junctional tachycardia can be congenital or acquired. So you can find it occurring in children who is just present at birth. It's congenital. and no other reason is congenital, or it can be acquired in those who are post-cardiac surgery. Post-cardiac surgery, pay attention. So it is tachycardia. So you want to control rate. You want to control rate. So control rate using digoxin. You can use amiodarone. Yeah.
I use either of them.
Okay, fine. So far, so good. Let's be sure we've not missed any question. Okay, fine. So we fire on. Sorry, our mouse. Oops, our mouse is. No, not that one.
Okay.
Okay. So
Okay,
the
now,
next slide.
Time for a small break.
So it's time for a small break. We've done quite a lot today. My question is, I hope the ECG session is going easy.
It's going easy, lemon squeezing.
Lemon
You're all following. I'm not lost.
Following. Yeah. So because so far today we've talked about the rate,
The rhythm.
the rhythm. It's very important. Rate and rhythm.
The rhythm.
I hope so far is so good. If my assumption is not correct, we would like to have your questions. But if we don't have your questions, we want to believe that so far is so good, and the ECG presentation can be said to be easy peasy,
Lemon
squeezy. Fine. Quiz.
Now this
Quiz.
now we're all listening.
Yeah,
very
so
well.
list 2 possible arrhythmias to look out for in post-cardiac surgery patients. So this child has come back from India. This child has come back from cardio care when surgery was done. Which
2 types of arrhythmias can we look out for possibly?
Yeah, so
Can we have
let's
some answers in
see.
the
So
chat box?
can we have some answers in the chat box? We wait. Yeah, so we wait. Can we have answers? Good. So we have tachycardia.
We need to know the type.
We accept.
We accept
So it's a good trial. We accept. But which type of tachycardia?
What do you mean?
Yes. Anyway, to our virtual audience, just to let you know that this is a hybrid presentation. In Limit Children's Hospital, we have our academic days on Wednesday. So we actually have a physical audience here with us also. So they may want to answer physically, or we get our virtual audience to answer. So someone has said,
already have
atrial flutter
junctional
and junctional tachycardia. Okay.
Do we have more answers?
We have more
I
answers.
think we have one atrial flutter.
Atrial flutter.
Okay, junctional arrhythmia.
Yeah.
Okay.
Sinus tachycardia, no,
No.
please. Okay, so junctional tachycardia.
Atrial fibrillation.
No. Okay, so fine. Let's explain. We said that atrial flutter, when there are scars in the atrium post-surgery, that's why I said like atrial septal defect being corrected. Although we know we want to use device closure for those who it is indicated for. Yeah, based on indication. So if there is a scar in the atrium, they are predisposed to atrial flutters. And then we also say for post-cardiac surgery patients could have junctional tachycardia.
Well.
So
those are 2 answers.
those are the 2 answers. So you can give yourself a virtual clap. Fine. So we're making progress. Wow. So what may this be? So this is staring in front of you. What could this be? Fine. P wave is absent.
And we have wide QRS complexes.
And QRS complex is so wide.
It
just has this bizarre shape. You cannot identify a P wave here. And then the QRS complex is so wide. Remember we said abnormal.
But it's wide, but then it's also regular, just to note.
Yeah,
it's
also
wide
and regular. So remember when we're discussing abnormal rhythms, we said P wave related, and then QRS related. Yeah. So for the P wave related was where we talked about absent P wave, talked about atrial fibrillation, talked about junctional tachycardia, and then we talked about P wave present but irregular, and we talked about atrial flutter. We now said, what if the QRS complex is there, but it's not narrow, it's wide? So who can?
And we have some replies in the chat box. Okay, we have VT.
Yeah, VT, yes. Yeah, ventricular tachycardia. Perfect. Perfect. Ventricular tachycardia.
Cardia.
Okay,
Oh,
let no, no,
Okay,
it's
someone
okay,
get
fine.
okay.
So let's go back to this slide so that we will just conclude on abnormal rhythms. Good.
So the
So
next one. Okay.
no, this rhythm. So if we take this, yeah. So wide regular QRS complex. So ventricular tachycardia, wide regular QRS
And with the
complex.
absent P waves.
Absent P waves,
as well.
ventricular tachycardia. Yeah. So this is it. So, all right.
I think we have more questions for our audience to follow.
Okay, fine. Yeah. So we've answered this.
Yes.
Okay, so let's see. Do we have more
No
questions?
questions. Now, okay.
Okay, for this, we don't want to ask you a
Ask
question.
it.
For this, we just want to let you again identify pattern. We said every pediatrician should be able to identify SVT. So if you have a baby in neonatal intensive care unit connected to cardiac monitors with at least a few of the leads, and you get the tracing on the monitor, you should be able to tell, come on, this is SVT, just from the pattern recognition. So if we have this kind of tracing, we have, this is ventricular fibrillation. Remember atrial fibrillation? This is ventricular fibrillation. In this case, there is this when the amplitudes reduce, increase, and you just don't find discernible P waves. So if this is for pattern recognition. It's important that we identify this tracing, because when we now start talking about shockable and non-shockable rhythms, it becomes important. So be able to identify ventricular fibrillation and differentiate it from ventricular tachycardia. We have these bizarre wide shaped ones, regular, and then we have this irregular looking amplitudes. Fine. So abnormal rhythms based on whether we can give shock, with our AED defibrillator or not. For ventricular fibrillation, which was the last slide you saw, if we find this in any child, we are supposed to defibrillate. If we find ventricular tachycardia, we're also supposed to. So it is, we give shock. They are shockable rhythms. It will correct it. Painfully, if we have asystole, which is just a straight line, no particular pattern, that is exitus. That is, I'm coming home. So that one really nothing. So a pulseless electrical activity, really no pulse, nothing. So it's non-shockable. It's non-shockable. Okay, fine. So let's make progress. Good. So quiz.
And we have this quiz.
So we have quiz. We would want answers from a hybrid audience.
Now he's on a monitor and it shows that he has a narrow complex rhythm. That at 25 beats per minute. SVD, essential tachycardia, or could it be a torsade de point or a ventricular tachycardia?
Yeah. So let's get your answers. We've discussed this before. Let's be sure if we are good enough, whether we are good enough teachers. So this child is 13 years old. So remember the rate discrimination, rate categorization rather between an infant and that child. Yes. So this child qualifies for an option that cutoff. We want to get answers.
So we have,
oh wow, we have answers already. We have answers already. We have answers. So this is interesting. This is interesting.
We have different answers.
We will, yeah. So fine. What do visual SVT complex is wide. So, but the question shows All right. Sincere apologies. We went off air. Please, I just want to be very sure that you can see my screen and you can hear my voice. Please. Okay, thank you. So we can hear.
Okay, thank you very much. Sorry for the interruption.
Yeah, so let's just be sure. Let's be very sure. Can we hear? Okay, I just want to be sure. So can we hear, please? Okay, yeah. So
okay,
Chinyeragu,
yeah. You can hear. Okay, thank you.
Okay, thank you. So we are back. It was a brief one. So we continue. We have answered this quiz. So we say it's sinus tachycardia. Yeah. Okay, so it's time to take a break.
And breathe.
Yeah,
it's been a long one.
It's been a long while. So if you can see my screen, I'm sure you can. Everybody prays to have this kind of beautiful. By the way, this looks like your voice spotter. It looks like your BQ. It's all right, fine. So we make progress. So it's important that we identify normal values. And then the pattern of normal values being related to age. Yeah.
Remember, one doesn't have to cram this. So
yeah.
You just have to at least be able to identify certain patterns.
Yeah.
Most of the time.
Okay, fine. So the pattern here, looking at PR interval, we can say that the PR interval lengthens
as we age.
With age. But the heart rate reduces with age. Yeah. So there is no flat cutoff. There's no flat rate for all children. Yeah, there's no flat rate for all children. So it's good to have this as reference also. Fine. So now AV blocks. Remember we said, so the video is still off, right? So remember we said abnormal rhythms include P-wave related abnormalities, QRS complex related abnormalities. So we are now looking at the QRS complex, which are now the AV blocks. Okay, fine. So we want to talk AV blocks now, but we want us to please watch out for the quiz ahead. For this time, we are announcing our quiz ahead of time.
You can watch out.
Yes, so fine. So, so for AV blocks, looking at PR interval, if the PR interval is longer than normal. Yeah.
I remember, but the normal is age related.
Now, good. Yeah, normal is age related. So let's just do a little exercise. So if you compare interval, let's say this child is a 2-year-old child.
2-year-old now.
We said this is simply 2 small boxes to 4 small boxes. That is the PR interval for age. 2 small boxes to 4 small boxes. So please, let's bear that in mind. So if we have constant PR interval, but longer than normal. So for a 2-year-old, and we are having 5 small boxes. At every time you measure the PR interval on the rhythm strip, the strip lead 2, we are having more than 5 and above. Then we say it's a first degree heart block. Now, if it's a PR interval is constant, but there is presence of drop beats, then we are talking about a Mobius type 2. But if the PR interval is lengthening, so at one point is normal, then successively, so successive PR intervals become longer than normal. In that instance, we are talking about Mobius type 1. Remember. So it's important we mention Mobius type 2 before we mention Mobius type 1. We are deliberate about the way we arrange the slide. So for PR interval that is longer than normal, but it is constant and there is no drop beat, first degree heart block. If the PR interval is constant, but there are drop beats, is Mobius type 2. The Mobius are type 2. The Mobius are second degree. So it's a type now. But if the PR interval at one point is maybe normal, then it becomes longer, and getting longer, then we say PR interval is lengthening successively. That is Mobius type 1. So it's important we bear this in mind. Good. Now, in the event we observe that the calculating the heart rate RR interval, there is bradycardia. So if there is bradycardia and PP intervals are constant, RR intervals are constant, but there is no relationship between the P wave and the QRS complex, then we are actually dealing with a third degree heart block. So it's important we know this, identify this. So let's go ahead to do the quiz. We are very excited with the responses so far. So let's see.
Okay, so now we have a strip of a 2-year-old. Remember the length that we put in our head the other time? PR interval.
Yeah, so we have already given the duration. We said 0.08 to 0.16. So that's to say the PR interval for a 2-year-old is simply between 2 to 4 small boxes. So if we see this child now, we quickly look at it. Please, what could this be? Is this a first degree heart block? Is this Mobius type 2? Is this Mobius type 1?
Is it complete heart block?
Or is it complete heart block? So let's wait for answers quickly, please. Sorry, we are working on the video, but I'm confident you can hear me. So let's make progress. Yeah. So is this slide for question number 1, a 2-year-old with this ECG tracing? What could this be? Is this a first degree heart block? Is it Mobius type 2? Is it Mobius type 1? Is it a complete heart block?
Okay,
wow.
We have some answers.
Wow, we have some answers.
We have first degree AV block by Kehinde Bello.
Yeah. Okay, fine.
First degree heart block.
Yeah, fine. So perfect. So let's look at it. So this 2-year-old child, if we take the rhythm strip now, which is which one? So normally we randomly look for a P wave where the PR interval starts from a big box. So if we take this PR interval is starting from this big box, and you see it, the entire length of the big box is occupied by the PR interval. And
that big box is about 5 small squares, which is already more than
which is already more than
what it should be.
Yeah. So that's that. So and every QRS complex is preceded by a PO. So there is no drop beats. And then the interval is constant. It's not lengthening. It's not lengthening. So if we see it meets this criteria, constant PR, but longer than normal. So it's first degree AV block. All right. So let's make progress. We're going to model things up now. Let's see. Fine.
Next slide.
What could this possibly be? Please look at the okay, so are you controlled? We have to. Okay, fine. Go ahead. So fine. So we have this slide in front of us. What kind of abnormal reading? What kind of heart block do we have? Please pay attention to the rhythm strip lead 2, the lowest strip on the tracing. What do we think this possibly could be? Is this a first degree heart block?
Is it a complete heart block?
Is it a complete heart block?
Mobius type 1?
Is it Mobius type 1? Is it Mobius type 2? So let's check. Let's check the answers. Okay, so we have second degree. Second degree. Is it Mobius type 1? Is it Mobius type 2? So we have it as first.
So we have a Mobius type 1 that someone just answered.
Okay.
Okay.
All right. So let's look at let's just get one more answer.
One more answer to see.
Let's get, okay, Mobius type 1, second degree.
Okay, we have Mobius type 2. Okay, Mobius type 2.
Mobius type 2. Yeah.
Yes. Okay.
Okay, so let's just wait. We'll see more. Let's just be very certain that. So the truth is that our audience, we have a mixture between Mobius type 1 and Mobius type 2. So we want to be very sure now. We have a mixture of answers. between Mobius type
Type
1
1 and Mobius type 2.
2.
But I think Mobius type 2 have it. I think they have more. They have
Okay.
more.
Okay,
answers.
fine. So let's look at the tracing.
Tracing.
So we see the first PR interval. So we find the P wave, and we are using. So we find the first P wave. So we need to use this. So we have the first P wave, and we find that the next P wave, actually, there is no QRS complex. There is no QRS complex.
So that's already one drop.
So there is a drop
bit. There's a drop bit there.
So, and once there's a drop bit, we are dealing. So let's go back. So I need to use the mouse. I need this color. Okay, fine. So let's look at our description. For that patient, we had drop bits. So automatically we say Mobius type
2.
Type 2.
Second degree AB block.
Yes. Well, let's see if really the PR intervals. Let's look at it. So PR interval here is actually similar with the PR interval here. It's similar with the PR interval here. So PR intervals are constant. If you can see my cursor, PR intervals are constant. But there is a drop bit at this point. There should have been a PR, so a QRS complex
after that.
Yeah, so there should be another QRS complex here. So when we have drop bits,
we have a Mobius type 2.
Yeah, so look at it very well. It's Mobius type 2. So let's see now the next question. So what could this be? What could this be? Which type of heart block could this be? Yeah, so wait for answers quickly. Okay, so let's just make progress and say this actually should be. In fact, let's get just one answer.
Just one answer.
Go on. Yeah, third degree block. Third degree block. Perfect. So because we see that, look at this is a P wave. We are lucky to have a QRS complex here. But there's another P wave here. There's another P wave here. Another P wave. So the P waves are actually equidistant. This is a P wave. The P waves are equidistant. The successive RR intervals are also constant.
And there's bradycardia. Really obvious.
So, but the P wave is not respecting the QRS complex, and there is no reciprocal respect from the QRS complex.
So there's complete dissociation of P wave and QRS complex.
Yeah, okay, fine. So let's try to move faster. We appreciate the audience.
The large turnout. We're very grateful.
Yeah, fine. So now, axis. All right.
So now what is the axis? So now the axis just shows us the direction of the electrical activity. Yeah. Now, usually there's an easy way of doing this.
So there's no video.
Okay, so we can use our thumbs. I'm sorry, the audience can't see me now, but we can use our thumbs. Let your left thumb represent lead 1 and your right thumb represent lead AF. So now if you have both thumbs pointing upwards, you have a normal axis deviation.
Yeah.
Now,
so normal axis.
So you have normal axis. So now you have two thumbs pointing upwards, lead 1 left thumb
and AVF.
And AVF right thumb, normal axis. Now let me turn down my right thumb. Now I have my right thumb facing down for the AVF.
Yeah.
Now you have your left thumb facing up. That is your left axis deviation.
Left axis.
So you have lead 1 facing up, lead AVF facing down.
Yeah.
Left axis. Now if you have lead 1, which is your left thumb facing down, and your right thumb, which is your AVF facing up, you have a right axis. Yeah. So now where your thumb is facing is where your axis is.
Yeah.
Now, if you have both thumbs facing downwards, which remember, lead 1 is left thumb, right thumb is AVF, you have an extreme axis deviation.
Yeah.
So this is a quick way of remembering it if you really need to know where what your axis is. So remember, lead 1 is your left thumb, lead AVF is your right thumb.
Yeah. It's okay. Perfect. Makes it very simple.
For us to remember.
Yeah. So let's talk a little more stuff, because we are going along the waves, P wave, PR interval, QRS complex. Now we come to the first negative deflection below the baseline is Q wave. it's important in pediatrics that we know the Q wave specifics for children. So Q waves are normally seen in the inferior and left lateral precordial leads. That's grammar. But you can see our slides, our ECG tracing here already. So lead 1 is a lateral lead. Chest precordial leads V5 and V6 are also lateral leads. It's important we know that. Now, the inferior leads are leads 2, leads 3, and AVL. Then anteroseptal are V1, V2, V3, and V4. It's important we note that very, very well. Having said that, we know that Q waves are normally seen in the inferior leads. So when we say inferior, we mean limb leads 2, limb leads 3, and AVF. Augmented limb lead, that's AVF. And then in the left lateral, which is V5, V6. Now, it is usually absent in leads
1 and AVF, and AVL in infancy. So you won't see it in an infant.
Yeah, in infancy. Okay, fine. So it's important when you now start finding Q waves. So Q wave is so much of a spot diagnosis in pediatric ECG that once we find Q wave present in lead 1, and AVL, but absent in the inferior leads. Remember, it should be in the inferior. Normally, it should be in the inferior leads. It should be in inferior leads. But now it's absent in the inferior lead. So no Q wave in lead 1, right? So you are thinking of Al-Kappa. Al-Kappa is anomalous left coronary artery from the pulmonary artery. So, but if we have presence of if it's present in the right precordial lead. So remember, although our tracing on the ECG on the screen now tells us about just says V1, V2, V3 for the right. We know we discussed earlier that V3R, V4R are also precordial. So if on V3R, V4R, or V1,
you have a Q
find a Q wave right ventricular hypertrophy. At least it's a pointer towards right ventricular.
Remember, so, in children.
In children. Yeah, so fine. If Q wave is present and deep in the left precordial lead, that's for V5, V6, then you're thinking of left ventricular hypertrophy. But never mind about chamber hypertrophy because we have a slide on chamber hypertrophy. But for Al-Kappa, we just want us to identify that it is present in lead 1 and AVL, and absent in the inferior leads,
especially 2, 3, and AVF.
Yes. Okay, fine. So let's.
Venice next slide will tell us more about the
Al-Kappa. About Al-Kappa. So this is a diagrammatic representation of what the coronary arteries look like. So the right coronary artery comes out from the just after the aortic root. So you have the right coronary artery. The left coronary artery should come out on the left side, let's say around the 4 o'clock position. Yeah, but we see in this diagram, it is rather coming, something. Okay. So rather it is coming out from the pulmonary artery. So we have an anomalous left coronary artery from the pulmonary artery. In that case, it satisfies the ECG abnormalities we have talked about, for which is our Kappa. Now, this is it. So this is from echo. When echo is done, this is the aortic root. At the 9 o'clock position, we can see the right coronary artery. But instead of finding the left coronary artery from the 4 o'clock position, we are discovering a vascular network on the position of the pulmonary trunk. Yeah. So we find the left main coronary branching to the circumflex and the left anterior descending. Now, this is a normal thing. This is where the left coronary artery should be. So Al-Kappa, and it's a common cause of chest pain in pediatrics. One of our subsequent webinar presentations, we shall be looking at chest pain in pediatrics, and so that we elucidate, we expatiate on those that are cardiac and those that are non-cardiac. Yeah, so this is just to mention
the ST
about ST segment shift. We are making progress already. So ST segment elevation or depression can be said based on whether it's a limb
Limb needs or a precordial lead. So usually if it's up to 1 millimeter above or below in a limb lead, or if it's 2 millimeters in the precordial lead, it is still within normal limits for the
so it has to be more than 2 millimeters for precordial
leads.
Above the base isoelectric line, ST segment elevation. Below the isoelectric line, ST segment depression. All right. So there are some non-pathologic variants of ST segment. So this is just to mention that the J depression, whereby we could get a positive slope going up between the S and T, is really not an ST segment depression, right? So this is for pattern. But the abnormal ST segment depression is a negative slope or a horizontal line.
It's more of an abnormal change.
So it's abnormal. So we can see classically that those are ST segment depression. Okay, so let's make progress. Our mouse is okay. All right, so pediatric T-wave details.
Now, this is very important to note as.
So we've talked about pediatric Q-wave details. This is pediatric T-wave details. Yeah.
Okay. Now, just know that now the T wave in V1 is usually upright in term infant. So you have a term infant and ECG is done. Usually see a T wave which is upright in V1.
Yeah, V1 now, or V3R.
Yes, or V3R. But now as the child grows older, now from the 7th day of life, the T wave then becomes inverted in V1.
Yeah.
This lasts about 7 years of age.
Yes.
Now just remember, between 7th day of life and 7 years old, we have upright T waves in the right precordial leads, which are V4R, V3R, and V1.
Yes. So it's important we emphasize this so that because our uncles in adult medicine I know when they say when the T wave details are different in pediatrics and adults. Yeah. Okay, so we want us to take a deep breath, relax. We've actually
gone through a lot.
It's good to stretch your legs, but not too long. We don't have the whole day, so I think we'll continue. All right, so ventricular disturbances. We are going to be very, very brief about this. So ventricular disturbances could actually be bundle branch block, pre-excitation, or interventricular block. Just to gallop through it, there's a right bundle branch block, left bundle branch block. Yeah.
I think the right bundle branch block, just to note really here.
Yeah.
Just note the M-shaped QRS pattern. Okay, I think. Okay.
All right. Okay, fine, perfect.
Okay. So for the right bundle branch block, just to note, we have an M-shaped pattern of the QRS in the right precordial leads. That's the
V3R.
Yeah, V3R, V4R, and V1 as well. But however, that same pattern is seen in the left precordial leads for a left bundle branch block. So remember,
V5, V6.
V5 and V6, that's for the left bundle branch block.
Yeah.
Also to note, in right bundle branch block, you can also see a terminal slurring of the QRS complex. That you may have wide and slurred S waves in lead 1 and left precordial leads for a right bundle branch block.
All right. Okay, fine. So let's go straight and let's ask. So please, we have some exercises. Our responses have been so reassuring. We are trying to make it far simpler because ATP, adenosine triphosphate may be dropping. Fine. So what is this? Is this a right bundle branch block?
I think we can use this small picture to help us know which one it is. So just try to identify the patterns.
So if you see QRS complex looking like signature, it's not looking what it should
look like.
Quickly check, is it in V1 or is it in V6? So what could this be? So who can please answer? Is this RBBB or LBBB? So can we please get answers?
Okay, we have perfect. We have a right BBB.
Yeah, so this is right bundle branch block. So we will want to get an answer from our physical audience in the next slide, right? So fine. So we have this here. Good. So exercise. Is this a right bundle branch block or a left bundle branch block? So look at the QRS complex. It looks unusual. How does it look like? Is this in V1, V5, V6? So is this a left bundle branch block or a right bundle branch? Yeah, so
Left,
so it's a
yes,
left
that's
bundle
bundle
branch block.
block.
Yeah, so we have a left
Bundle
bundle
branch.
branch block. So that's simple. We know that the other parameters like right axis deviation for right, but then you have the slides and you can actually go through that. So, but because of time, now this is pre-excitation. So fine. In pre-excitation, PR interval is shortened because there is a delta wave. Now, if you look at the diagram, the tracing here, PR interval should have been from the beginning of the P wave to normally where the QRS complex is supposed to be.
The normal tracing.
The normal tracing. However, there is a slurring at the beginning part here, which is a delta wave due to early conduction through an accessory pathway.
So this can be seen in Wolff-Parkinson's White.
Yeah, Wolff-Parkinson's
as well, where you have this kind of short PR interval.
Yeah, fine. So let's see the next question. Let's see. So fine.
Now, what do these
arrows point to? We have arrows here. Please, your answers in the chat box. What do these arrows point to? Okay, so we have a question. Explain the RSI. We'll do that.
Okay, we'll do that.
We'll do that. But actually, it's the M-shaped, the abnormal M-shaped. Yeah. Okay, so what do these arrows point to? Who can please tell us? Okay.
Yes, we have
delta waves. Yeah. So was delta wave discovered in delta state? I don't know. It's all right, fine.
Okay.
So now chambers. We are gradually wrapping up. Chambers, yeah, good. So we'll start with atrial.
Yeah. So I think let's have the normal one.
So
now we have normal one. So now the P wave should not be more than 3 boxes vertically, and 3 small boxes horizontally.
Yeah.
So now if you have a right atrial enlargement, you're going to have more than 3 boxes. That's
in height.
In height now, vertically now. And it's also called P pulmonale. Now, if you have a left atrial enlargement, you're going to have wider than 3 small boxes, or you may have a notched.
Yeah. So it's longer
and it's also with notch too. I if say by atrial enlargement, you're going to see both features.
Yeah, both features. Yeah, so if you look at this cadaveric specimen, you find out that this is normal cross section. The atrium is normal, but atria enlarged in this condition. So having known this, we're going to ask some more questions to be sure we are together. Please, right atrial enlargement, the P wave in lead 2 is taller than 3 small boxes, and then for left atrial enlargement, lead 2 is longer than. So let's see, what could this be? Yeah.
So remember, please look at your rhythm strip.
Yeah.
Lead 2.
So for now, we are just focusing on lead 2.
On lead 2 for now.
So looking at lead 2, please, what may this be? Is this left atrial enlargement or a right atrial?
Or is it by atrial enlargement?
Or is it by atrial enlargement? Yeah. So waiting for questions. We have some very hot cardiologists in line. Let's see.
Okay, we are seeing one right.
So someone says right atrial enlargement. Let's see.
Let's see any more.
Let's see. Can we get 3 answers and plot our graph, our line across?
Take our average.
Yes, and take the average. So fine.
Okay,
so we now have a left atrial enlargement. Another person say right atrial enlargement, left atrial enlargement, P mitrale. Okay. So we are having a lot of answers here. So now let's come to the panel of judges. All right, fine. So lead 2. If we look at the PR interval, it's actually about 5. It's almost about 4 to 5 small boxes horizontally. And there is actually a notch. There. So we can conveniently say this is P mitrale, which is left atrial enlargement. Please, this is T wave and not a P wave. So this one my cursor is touching, it looks really tall. It's actually a T wave, not after the QRS. Yeah, it's not a P wave. So we look at the first positive deflection before the QRS complex. It's not taller than 3 small boxes. So it's actually not a right atrial enlargement. Fine. So let's see the next one. Good. So we have arrows pointing down.
towards it.
So is this a right atrial enlargement or a left atrial enlargement? We can get from our physical audience, right? So let's see between our physical audience and our virtual audience, we have this arrow.
Yes, we have right atrial enlargement.
So yes, yeah. So right atrial enlargement. So why? Because the P wave is, so for right atrial enlargement, many times P wave is taller than T wave.
T wave, yes.
Because P wave is taller than three small boxes horizontally. All right, so ventricular hypertrophy. Now, we want a disclaimer. Then there is more to ventricular hypertrophy, but we said at the beginning of this presentation, we want to make it that anybody that attends this webinar will be able to make a meaningful report of the ECG. Now, ventricular hypertrophy is not only based on precordial leads, but for the purpose of this presentation, we are only emphasizing on precordial leads. Mark my words, you will not miss it, even if you use just precordial leads. And the precordial leads, we're looking at all the waves. So Q wave, R wave, S wave, the voltages. Yeah. So if it's right ventricular hypertrophy, we know that the right vectors are in the precordial lead. So if we have Q wave present in V1, your mind goes to right ventricular hypertrophy. Now, if you have R wave, so present, tall, that's prolonged, that's very tall R waves. Now, the next slide is actually going to give us another number. In fact, let's look at it. Normal values. So, okay, fine. So we actually have normal values for R waves. So these slides will be given to us. They should serve as reference values. However, let's go back. From morphology, we can actually tell if the R wave is really tall, more than normal in V1, V2, or V3, V3R, V4R. You're thinking of right ventricular hypertrophy. Now, S wave, you know, S wave is, so you're looking at S wave in V5, V6. If S wave is deep, more than 5 millimeters, if S wave is deep in V5, V6, you're talking of right ventricular hypertrophy. We can stop at that point. The RS ratio, when you read the slides, you understand. It's actually a combination of what we've said so far. Now, if T wave is upright in V1 from 1 week, so that's from 7 days to less than or equal to 7 years. So right ventricular. So if we identify a right axis deviation, so all these make for a right ventricular hypertrophy. Good. I hope we are going to be able to identify the next slide and tell us if it's a left ventricular hypertrophy or a right ventricular hypertrophy. We are open to questions. Please, in case there are questions, we are ready to answer. So if it's left ventricular hypertrophy, it's actually an inverse of the right ventricular hypertrophy. So because left ventricle is more towards the left precordial lead, so V5, V6, and having Q waves, if Q waves are deep, more than 5 millimeters in V5, V6, good. We are not actually talking about voltage criteria like our uncles, our uncles in adult cardiology use. Because I've actually had to reassure after one of our big brothers had reported left ventricular hypertrophy in the child of a doctor, and the doctor could not sleep for 2 nights until they referred them to Limit Children's Hospital. Well, we proved from the tracings, all this, that the child had normal ventricularity. It was for preschool. It was for preschool enrollment. Yeah, we even had to do echo to convince the person. So these are parameters for left ventricular hypertrophy. So let's just move. So fine. So looking at precordial leads, which chamber is enlarged? Here, we said we have other parameters, but for the purpose of this presentation, we have focused only on precordial leads.
V1 to V6.
Yeah.
V4R,
so who can tell us what is this pointing to? Left ventricular hypertrophy or right ventricular hypertrophy? Remember our Q waves. Do we have deep Q wave in V1? Look at the R wave. Is it really tall? Does it really look tall to you, or it looks normal to you? So we are prepared to get answers, please. So we have answers already. So right ventricular hypertrophy, right? Yeah, so perfect. So there are Q waves there, the R wave, tall R wave. Now, if you come to V5, V6, you see that the S waves are so deep, more than 5 millimeters. Yeah. So more than one big box, right? So this is actually a right ventricular hypertrophy. Fine. These are the normal values for us to understand. Now, we have this beautiful tracing. So we call it KW phenomenon, Whichever phenomenon. So we have it in front of us.
It usually shows us when there's a biventricular hypertrophy.
Yeah.
So what it means that you have equidistant, that's the amplitude of the V5 and the V6, the R wave are usually almost the same.
Normally we talk about what we call the left ventricular transition zone. So left ventricular transition zone here, it's prolonged from just V to V3. So from V2 to V5, you have R wave and S waves equal.
They are all equal.
R wave, S wave equal right from V2 to V5. This is unusual. It doesn't go as far as V4, V5. But in this case, you have it. Mind you, we say ventricular hypertrophy. So you find the features of left ventricular hypertrophy, you find the features of right ventricular. Let's look at, so you find them here. So it's actually the whichever phenomenon, that's biventricular hypertrophy. Yeah, so wrapping up, we say common ECG patterns in congenital heart diseases. For atrial septal defects, we know that you could have a right axis deviation. So for what is right axis deviation from getting axis?
Okay, so remember we have our lead 1 as our left thumb and our AVF as our right thumb. So now if it's right axis, you're going to have your AVF facing up and your lead 1 facing down.
All right, fine. So there's right axis deviation, then there's mild ventricular hypertrophy. Remember, there could be right bundle branch block. Yeah, fine. So the right bundle branch block, someone asks what is the RSR pattern. That's M-shaped. That's on signature-like thing that occurs on the QRS complex. If it's present in the right precordial leads, you are thinking of a right bundle branch block. Now, for a ventricular septal defect, if it's small,
that's less than 4 millimeters.
Yeah, if it's small, you have a normal ECG. So this is trying to tell us that a normal ECG does not rule out a structural cardiac lesion. This is a very good point that we should know. Note that a normal ECG does not rule out a structural cardiac lesion, because if the VSD is like a 2 millimeter VSD, you want to find, So if it's a moderate one between 4 to like 8 millimeters, you could have left ventricular hypertrophy and left atrial enlargement. If it's large, the answer is biventricular hypertrophy. Yeah. So the findings, ECG findings in PDA are similar to those of a ventricular septal defects. Superior axis is for endocardial Cushing defects. Fine. So we will just talk about this in the emergency room or pediatric intensive care ward. If we have these changes in the ECG, we know that many times getting electrolytes may take some time, but it is real time to be able to interpret potassium levels if this child is connected to a monitor, or we can quickly do the ECG tracing. So if we have
so let's look at it in the lead 2 and the left precordial lead.
Yes. Lead 2 and left precordial lead. So a lot of our readings have been looking at lead 2 as a reading strip. Yeah. So this is normal. So the normal one has a normal tracing. Yeah. So the normal potassium levels have normal tracing. Now, if there is hypokalemia, mind you, we have depressed ST segment. See, the ST segment is horizontal. Here is depressed. Yeah, this is not like the J depression that has an upward slope.
It's one that has the horizontal slope.
Yeah, this has a two. So depressed ST segment, a diphasic T wave. So we had P mitrale, which had P wave with a notching to tell us left atrial enlargement. But now we have a diphasic T wave. That's a T wave with a notching to tell us hypokalemia. So now in hyperkalemia, the beauty of ECG is that it changes with the level of the hyperkalemia. So if we have just a tall T wave getting almost as tall as a R wave, you know that the potassium level is greater than 6. If we have QR PR interval now prolonged.
You have a wide PR
Wide PR.
restoration.
So everything
and
is
you
getting
wider.
unusual now. The only unusual thing, if you find the only unusual one as tall T wave, then it's more than 6. By the time PR interval, QRS complex, T wave become longer than what it's supposed to be.
It's more than 7.5.
By the time it's getting more than 9,
you have a sinusoidal wave appearance.
Yeah, so something very quick has to be done. Yeah, so ambulatory ECG monitoring is one of the end. We want to rule out cardiac arrhythmias in children with chest pain.
So you want to check and see if your therapy for arrhythmia is working.
Yes.
Start making progress.
Yeah.
So you want to also screen for arrhythmias when you have cases of post-cardiac patients from surgeries.
Yes.
So things like atrial flutter can then be seen as well.
Yeah. Okay.
And also to evaluate if there is pacemaker failure on those that have been given the pacemakers well.
Okay, so one of our children we just discharged had a pacemaker. Well, it functioned well all through. So we want to evaluate. So that's it. So to screen for arrhythmias in selected cases like hypertrophic cardiomyopathy or post-cardiac surgery. Mind you, we said that junctional tachycardias
and atrial flutters can be seen.
Yeah. Okay, fine. So so that's that for ambulatory. So ambulatory is more than just a snapshot. So in our facility, if we have to do ambulatory, we send the patient to our cardiac center, and usually they will have to stay in the hospital for that, because I think it's expensive to attach the ambulatory one and go home. You travel home and we cannot get it with dollar exchange rates. No. Okay, fine. So in conclusion, we want to assume we've tried to make pediatric ECG
easy
peasy, lemon squeezy, so that there is value for your time. But we want to say that practice makes perfect. These slides will be sent to you, and you would have time to go through the slides as much as possible. So you practice them systematically so that you remove the enigma around.
It removes the mystery.
So I hope we've been able to demystify ECG. Yeah. Also, we know that
also that a normal ECG does not rule out a structural cardiac lesion. So even when you take proper clinical history, you have to auscultate. It's for more. You still have to go ahead and do an echo to confirm there's any structural cardiac lesion in the guest.
Yeah. So we must always correlate the abnormal ECG findings with the clinical picture of the child. Wow. We want to thank you all for sustaining your audience. We don't know if we have questions in the chat box. We will give you the notes. We'll give you the notes. Yeah. So we don't know if we have questions. We are prepared to answer, and we are very, very sure that our respected colleagues are also listening to us. And if it goes beyond mathematics to further maths, we know some people already who will answer. We want to give respect to our seniors who joined. We are very proud to have you joining us. So if there are questions, we are ready to answer. Yeah, okay, fine. You're going to get the slides. So with the email you registered, be rest assured you'll get the slides. Okay, fine. So we would have a presentation from one of us. Yeah. So while that's going on, if we still have questions, if we have any questions, you can still put it in the Q&A. Yeah. Okay, so in the next few minutes, we're running up, but just to hear. Yeah.
Okay, good evening, everyone. My name is Mrs. Pamela Ohanenje Albai, Corporate Relations Manager for the Limi Hospital Group. I'm just here to brief all of us, give a brief presentation on Limi Children's Hospital, how you can reach us, how you can refer, how we can partner, and how we can collaborate with you. Before I proceed, I'd just like to mention that Limi Children's Hospital is a designated specialty hospital for pediatrics, neonatology, and general medicine care for children. And we're located at number 39 Ademola Adetokunbo Crescent, Wuse 2, Abuja. Limi Children's is also an arm of the Limi Limi Central Healthcare Center. And we have been in business for a very long time. One of our strong specialties is neonatal management and our pediatric cardiology as well. So Demystifying Pediatric ECG is brought to you by Dr. Peter and Dr. Omokhuale, and it's part of our continuous medical education to reach out to other healthcare providers, other healthcare professionals, to share ideas on the WhatsApp group. So my name again is Pamela Ohaneje Awai. Thank you so much for joining us today. And I promise to send this slide across to you before Wednesday next week. If possible, by Friday this week, you should have it in your mail. If you have questions, if you have inquiries regarding everything I've said, please drop into the question and answer segments, and then we'll get back to you with an answer. Thank you very much.
All right, thank you. So we have this, the presentation has actually ended, but we have just one question, and maybe I just project the slide. Maybe I just project the slide. The person said we should still talk about the chambers, that's left ventricular hypertrophy, right ventricular hypertrophy. So this is it. I do not know. We are giving it out, the slides, but we are talking about, we are going through using the waves, Q wave, R voltage, S voltage, and all that. So it's as is stated here. I hope it makes it very simple. We're able to identify this as actually a right ventricular hypertrophy. Yeah, we're able to identify this slide right in front of us now as a right ventricular hypertrophy. Why? Because the R wave is really tall here for age, presence of Q wave in V1, and then a deep S wave in V6. So it tells us this is actually a right ventricular hypertrophy. We are so happy to have had you sustain attention span for this long. We will wrap it up today, but there is another interesting session by our pediatric neurology team next month. So our consultant pediatrician and child neurologist will be on air same time next month. Watch out for the adverts, and I'm sure you also find it exciting. Thank you. Yeah.
The Limi Children's Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.